I just want to say hello to everybody. My name is Karen Uchida, and I'm a patient advocate and a volunteer, and I'm also a baby boomer. And I'm a late diagnosed scoliosis patient. So I found out when I was 27 years old that I had scoliosis, and I was told not to worry about it, wouldn't get worse. 14 years later, it did get worse, and I had to have a 16 level fusion, which was life-changing. And on June 21st, 2023, I was baking muffins and watching the CBC, and all of a sudden I saw my spine surgeon on TV. I was shocked, and I discovered there was this, health crisis going on in Ontario. So I reached out to my surgeon, and we ended up drafting a petition. And so I spent a year, getting all these signatures and having all these MPPs present this petition to improve spine care access for mostly scoliosis patients, adult patients in Ontario. But then I discovered it was a national problem, and I saw all these other CBC articles on children waiting way too long for surgery, and specifically, I saw one written by Jennifer LaGrasse and Amina Zephyr from October 1st, 2023. And there was a byline that really caught my eye saying, Canada stopped checking children's spines years ago and why experts say screening should come back. And it was a race against time to prevent severe spine curves. And I also went on Facebook and I found all these support groups for scoliosis patients. And it was just heartbreaking to read these stories. It I couldn't believe it. And I thought I have to do something. So I spent weeks doing research like a mad person, reading every study I could find on adolescent idiopathic scoliosis, why screening had stopped in Canada. And then I started reaching out to the people that was in the CBC article, and Andrea was the first one, and then Dr. Jean Oulet and these other people. And then I just kept going and recruiting more experts across Canada. And that's how I formed this, and also start looking for patient and parent advocates and groups. And that's how this coalition formed, this nonprofit coalition. And our main mission, as you all know, is to establish early detection of scoliosis through screening. And I ask everybody, I advise everyone to visit our website, www.scoliosiscanada.ca. You'll see our mission statement, and that explains everything. And there's also our who we are. So it lists everybody's bios, because there's a lot of people in this coalition, a lot of dedicated, compassionate, hardworking people. So this is our first webinar that's targeted towards not just parents, but health policy makers, because we want to change things and get screening back to Canada and better care and resources for scoliosis patients. And we can only do better. I was so mad to find out that all these other countries in the world were doing screening. Japan's been doing it since 1979. They do all these, genetic studies, and all this research is going on, and it's not happening here. There's some research going on, but there hasn't been school screening since the 1980s, and even then, it wasn't really well done, or wasn't that wasn't everywhere, because I didn't have it in my school in the 70s. I should have been screened in the 70s, and there was no screening in Hamilton, Ontario back in the 1970s. And I heard from other people that they didn't have screening in their cities or little towns either back in the 1970s. And so, and today there's been so many advances in technology and science with surgery and better screening methods and tools that, there's no excuse that we shouldn't be doing this. I also find I was kind of well, I guess I wasn't too surprised. I always felt it was genetic, but I read like dozens of research studies, and I discovered this is a genetic disorder, and it's what you would call polygenetic, where the research scientists, they've identified 3 genetic variants so far, and it's also multifactorial, it's called, where other factors such as endocrine hormones during puberty can affect the progression of a curve. So that's important to know. So, but we have to change things in Canada because I discovered it has preventative disease burden. And seeing Dr. Oulet's, is it Oulet? Oulet's video on YouTube, I learned a lot. And he's the one who, stressed that this has preventative disease burden, and that's bracing and scoliosis-specific physiotherapy. I never heard of Schroth. Found out, met Andrea last year, and I did all this research, and I was just blown away, that this Schroth existed. They're doing it in Europe. They're doing it in China now, and it works. So we have to change things in Canada. And another thing, a message to health policy decision makers and governments, it saves money. You will spend less on health infrastructure if you do this, preventative screening, because bracing and physiotherapy cost less than surgery. Not that every kid is going to benefit from the studies of it. It doesn't work for every kid, and there are different curves with scoliosis. So, but I read up to 72% coronary studies can be helped, and I've seen studies from other countries that do screen. They save money. I've seen studies from countries that used to screen, stopped, and then they published saying, "Oh, our numbers have gone up for surgery." Kids presenting at clinics are presenting too late to be braced, and they have to have surgery. And that's what's been happening in Canada for years now, well, decades probably. And it's traumatizing to parents to find out, their child has a severe curve and they didn't know about it. And it's a shame. And it's something that it's unnecessary. And I think it's a moral imperative that we have to fix this, and that Health Canada and each province, health ministers, they have to do something about this. If 29 US states are doing it, and I put it online on our website through publications, they can use that as guides. Provincial health ministries and education ministers can look at these guides and will help them set it up in their own province. If they can do it, if Americans can do it, yeah. If Americans do it, we can do it. So I'm going to first introduce Andrea Lebel. She's our first presenter and panelist, and Andrea's got an amazing resume. She's Canada's first Schroth physiotherapist. She opened a physiotherapist clinic in 2008, and also this resource center. She's been organizing these walks every year and raising tons of money for the local hospital in Ottawa, CHEO. And she's just unbelievable. She has people coming from all over Canada to learn from her. She teaches Schroth, and she has patients and parents driving from hundreds of miles away to bring their kids to her. And she's put in years and years of advocacy where I couldn't believe what she's done. I just, hats off to you, Andrea. I don't know how you're still standing. So I'll leave it to you, Andrea, and I'll give you the floor now.
Anyways, thank you very much for the introduction, Karen. I'm honestly not standing, I'm sitting, but I'll try my best to show a little bit of an input what has happened over the years in Ottawa, and what is going to need to happen in the future. All right, so my name is Andrea Lebel. I'm in Ottawa, a physiotherapist, and I am also a patient, a scoliosis patient for over 50 years, and a physiotherapist over 40 years. And I would like to talk about the awareness issue in scoliosis, as well as how the role of the physiotherapist is changing when the therapist is treating scoliosis patients. So I operate a physiotherapy clinic in Ottawa. I also operate a resource center, as Karen said, and over the years, I had many hats to wear in local and international societies and boards. I'm just going to start a little bit, since we have a variety of audience of scoliosis, scoliosis being a three-dimensional deformity, and it is multifactorial, as Karen said, and it is mostly affecting healthy children. We call it idiopathic because we don't know one exact cause causing all the scoliosis. So, as Karen said, yes, the DNA and the genetics hugely affected, just like the hormones and biomechanics, as well as some protein, according to Burwell's publication. And we know that we have a huge research on osteopontin in Montreal going on as we speak. The prevalence rate of idiopathic scoliosis is quite high. 3 to 5 will be diagnosed, 3 to 5% of the age group, and 1 to 3 will be braced, and 1 will end up in surgery. 10 times more girls are affected than boys. And this is unfortunate how it works for our children. They go to a soccer game, they have a good time, and from one second to the next, they will be diagnosed late. Every 13 is diagnosed late in Canada, and they're ending up in spinal surgery as it is late diagnosis. They cannot access any other type of treatment. Oops. Sorry, I have to find a way to advance. The scoliosis have visible signs, uneven shoulders, uneven rib cage, rib hump, space between the arms and the body, and uneven pelvis or pelvis shift. And these are the signs and symptoms which we'll try to look for. And the visible signs, the rib hump, which is not a pretty name, but the rib prominence is the most common sign the parents notice on a child, and this is the only reason often they seek help. How my scoliosis journey started when I was age 12, I was screened in a school system, and I was directed to participate in intensive Schroth type of physiotherapy, scoliosis-specific physiotherapy for 4 weeks, and then followed in the school system 3 times a week in the special physiotherapy education groups. So that's a very important message that unfortunately I would love to see the same kind of services 50 plus years later in Canada. Canadian history, scoliosis was screened but discontinued in the 1980s based on a large study in Quebec. Since then, late diagnosis is 32% plus higher since COVID, which means every child who's diagnosed late is already close to surgical range. The lack of early diagnosis leads to progression to scoliosis surgery. And since 2013, we know and we have very strong evidence that this could be prevented by bracing. Timely bracing alters the natural history of scoliosis and decreases the number of surgeries. Scoliosis-specific physiotherapy or physiotherapy scoliosis-specific exercises, PSSE, is evidence-based, and publications state that PSSE should be added to the standard of care. We have more and more publications, Canadian publications and evidence showing these type of research. No school screening in Canada since 1980s, and you can see school screening in Ghana. It's a very poor country, and they have an excellent scoliosis program and hospital led by Dr. Boachi, who was the SRS president in 2009. And if the early signs, when the children are wearing t-shirts, if the early signs would be just so simple that we see the signs and symptoms, would be not a big problem to have the early detection and finding the curvatures early and having the children start treatment. But since the early signs are not easily visible, a routine exam from an orthopedic surgeon or pediatric specialist can spot this condition but an untrained eye may not be seeing this condition very early. So early detection is key to avoid severe deformity, and several international societies are standing by this statement. No child elects to wait, and the cost of the healthcare with this delay is an incredible $44.6 million, according to the Conference Board of Canada, published in 2023. And this incredible amount of wait time expense could be easily transformed into early screening and early treatment, non-surgical type. So we need to reduce the wait list, and we can if the children are screened and treated by evidence-based bracing and scoliosis-specific physiotherapy. Timely diagnosis can allow for more treatment options, and therefore fewer teens would be waiting for surgery. Not only this is better for the patients, but also for the healthcare system. Thousands will be diagnosed late this year for scoliosis, and thousands will be missing out on bracing and PSSE and will be waiting for surgery. Currently, according to Children's Healthcare Canada publication, 2,778 children in Canada are waiting for spinal surgery. This must be eliminated. The waiting time must be eliminated, and a late diagnosis must be eliminated. If the patients are wearing the braces as much as we hope they would, then the brace is successful about 75% of the time from preventing the scoliosis from getting worse and requiring surgery. This is stated by Dr. El-Hawari, a spine surgeon. However, because of the late diagnosis or long wait time to get to the hospital, often children and teens miss out the window of opportunity of less invasive treatment. Thousands will be diagnosed late this year without screening, so we must screen out scoliosis. Public scoliosis awareness is very low since the discontinuation of the screening programs in Canada. The last 40 years, the word scoliosis doesn't mean much to the public, and very few people are aware of this spinal condition. The lack of screening resulted in a lack of knowledge about the spinal conditions. Newly diagnosed families are shocked and need to spend a lot of time learning about the condition, or even more time to research potential elective treatment options. The lack of screening resulting in more surgeries and variety of referrals, according to the publication below. This is how the patients are educated. How do we screen and diagnose scoliosis? With the Adam forward bending test. A handout showing here the Adam forward bending test is not an early detection. This kid already has a very severe scoliosis. So we have to educate professionals and families on the milder signs and symptoms of scoliosis for early detection. How can we all bring scoliosis awareness and advocacy across Canada? Raising public awareness and education, educational campaigns and local activities in the community, involve advocacy, try to unite families and professionals, advocate for scoliosis awareness. You can write many, many letters to get your MP involved, and promote early detection and treatment no matter really where you go. Highlight the importance of early detection and the intervention to make sure that screening will be done again in Canada. Volunteers building communities and create networks of communities, collaboration, and allowance to help sustain and grow the campaigns. Community events during the month of June are essential, and of course, throughout the year would be very advisable. Submit proclamation, to ask for Scoliosis Awareness Day in your community. And ideally, one day we're going to have a Scoliosis Awareness Month, a month of June, just like in the United States. Raising awareness for scoliosis over 25 years. I've done many things over the past 25 years, not just going to schools and educating students and teachers and gym teachers and trainers, but also giving out information to the schools, information nights through the community, and create family support groups in the clinic where patients and families could come, whether they are patients or not, the doors are open, and provide education through art, bus signs, TV, medias, and during fundraiser events in the community. So just a couple of little samples of that. And community events were also available for nurses, MDs, PTs in community centers. Teaching PSSE courses for professionals is what I try to do to pass on the knowledge. So this is just a little photo of our resource center, which is open since 2008, and until COVID started, we met once a month on a Friday afternoon or evening when families could come and be educated more on the available resources, as well as the most popular program to brace your parents. You can see the children can put braces on their parents, and here the whole family has been braced. The teen obviously need a reason to be braced, but the parents now can understand how they feel with the bracing treatment. So it's very nicely bringing families together, teens, peer supports, and through the handout and education, hopefully we reach others and having earlier diagnosis and awareness. We use the spine crane and teaching them how to use momentum health as well for making sure that they can monitor their progression or scoliosis. Many apps are available. At the clinic, I prefer to use the Momentum Health, and it's an excellent app. And for the parents, it's available. And in the past, we taught the parents how to use the spine screen so they can screen at home the siblings and the neighbors and everybody else who are at the risk of this age of progression. With the local support groups, we hosted not just Kirby girls for 6 years, but also now Higgy pairs are growing. And we have also a clinic support group, which is now not meeting necessarily every month, but if a patient would like to have peer support, we pair them up with other teenagers, other families who are going through the same history and same treatment. We had a huge support from past CEO Alex Munter and Dr. Lawton. You can see orthopedic, head of orthopedics, coming to the support group meetings and helping us to hire a nurse practitioner at the Children's Hospital here who can take care of the non-surgical children and to produce more educational information for the families. We brought a play in from New York. So this was very, very popular in Ottawa. Over 2,000 teens have been educated on scoliosis. This is at one hand up in a huge gymnasium, about 400 kids, when one of our presenting a slide of her scoliosis, asking who knows anything about scoliosis. One hand gone up. So it's important for starting the awareness, starting the education, in a teens where the school, all the teens present and they study and learn, and bring some other ways of educating them on scoliosis. So the brace play was traveling around in many schools, and it's a one person play. It was a fantastic play. A Canadian actress who is living in New York wrote this play and presented of her own scoliosis history. And we appeared through Kirby Girls and through the support group in many magazines, newspapers, media to increase awareness. And we had two team leaders who were very actively reaching out to other leaders, other patients, and other families who needed support. We raised funds and awareness throughout not just the bus signs, but all our events to support the local hospital. And we have the annual Scoliosis Awareness Walk since 2012. We had a little pause during COVID, but we're back again. The next walk is on June 7th. We have politicians, Prime Minister's wife, Mrs. Harper joined us, and the CHIO team coming to walk with the patients. When we have these events, we always show how to screen for scoliosis and demonstrate the Adams forward bending test, whether we are teaching in a community center or during any of the events. You can see CHIO spine surgeons and politicians here demonstrating the screening. And this is also a couple of pictures of our proclamation. I do teach how to screen the community centers across Ottawa whenever they have an educational seminar, and I teach them how to use the scoliometer as well as applications. So if you can reach out to your communities and have the public health nurses learning that would be great. We try to reach out to all the family doctors through the Ottawa Public Health, and that was very, helpful for most of the medical doctors who were able to learn a little bit about scoliosis. Unfortunately, our family doctors in Ottawa don't own a scoliometer, so they just looking at the children. Sometimes they refer them with muscle spasms, sometimes they refer them with rib prominence, but not actually diagnosing the scoliosis, but often refer them to X-ray, which is able to identify the scoliosis, unfortunately, most of the time pretty late. Through the CHIO outreach program, we reached 4,000 healthcare professionals to educate them on early detection and lots of other ways to reach the medical community to make sure that the scoliosis screening is happening. Unfortunately, we don't have an established program to screen for scoliosis. When I hold my courses where participants from health professionals, all traces of lives come to learn about spinal conditions. We always spend a lot of time to identify the scoliosis and make sure that they know which are the curves which are good for fitness exercises or other exercises, and which are the curves which should be receiving more attention depending on your age and obviously curve angle to refer them to special therapy. Learning is available online. Everybody who's interested, we have free programming in this international learning platform. And learning is the base of finding the right way of treating as well as the right way to identify the patients who need treatment. This is the SRS guideline, very simple, based on bone maturity, curve magnitude, and the action of treatment. You can see that on the SRS guidelines not showing PSSE, but bracing is included. We have a lot of children in the gray zone, and the gray zone, we don't have any action. You can see that it's kind of empty there. We also follow the SOSOT guidelines. The SOSOT is an international organization where experts come together and bring a guideline on the treatment based on curve angle, bone maturity, age, and provide minimum and maximum treatments. And I was fortunate to be participating in these guidelines preparations. And this is just for seeing what is the difference in terms of the treatments when we have an early detection. When we have early detection, there's education, which we can implement. We can continue observing patients when they are very low carb angle. We can see the progression, and they might enter in the pre-braced or bracing treatment period. And if that doesn't work, or they are late diagnosed, they are already here. So a late diagnosis patient missing out on all these circles, all these level of care, which is always accompanied by PSSE. I was fortunate enough to also be part of the best practice guidelines in Colombia, led by Dr. Vitali's team, and with with the great agreement with bracing treatment, it's highly recommended to add the scoliosis-specific physiotherapy to a combined care. This is Dr. Buachi, who was the SRS president in 2009, and he stated, he's a spine surgeon, and he stated out of 10 patients coming to his office, he only wants to do surgery on one. The other 9 will be referred for physiotherapy or bracing. Now, it is a very important statement because I think the 9 other patients who are not seen by a spine surgeon anymore need to have the same level of care and the same funding, just like a surgical patient. In Canada, the surgery is fully funded, but scoliosis-specific physiotherapy is not. What is scoliosis-specific physiotherapy? It's a very old technique, over 200 years ago, started in a Lyon method, which is slowly grown as the tree here into many other methods. And these methods are the ones which have been published or have some RCTs showing their evidence. These methods have been published, 7 of them in this publication. And since then, we added other methods who have more evidence, CLAP and some RPG in Quebec, and scoliosis Schroth-based therapies. And this publication is available for online when 7 scoliosis-specific therapies are very well explained. These are therapies which are published and have some great high level of evidence. What is common in all the different type of scoliosis-specific exercises? What is common is the auto self-elongation, the stabilization of the curve, information for the patients, and education on the active daily living activities and postures, and restoration of the sagittal alignment. So no matter which scoliosis-specific physiotherapy the patient is treated with, these are common goals. I'm going to talk a little bit about the Schroth physiotherapy, which is started with Katarina Schroth back in 1921, over 100 years ago. And herself was a patient, a scoliosis, living with scoliosis, and developed the scoliosis method, which helped her condition. And alongside with her daughter, Kristen Schroth, they were treating patients in their backyard, as well as the most important publication here in 2007 by Crystal Schroth reached worldwide, and we know more about Schroth method since then. The Schroth method is based on a very specific orthopedic breathing, also called rotational angular breathing, where the collapsed areas are opened. Here is a collapsed area of the rib cage with a very, very severe kyphoscoliosis. And with this breathing technique, we're inflating just like a ball or a balloon, this area to open up, and we use isometric tensions around the prominences to stabilize the curve from further progression. When you see a patient with severe curvatures and you take an X-ray, and when you see the same patient during exercises, Back then, they checked that with the x-rays. Now we have more evidence by ultrasound technique showing that during the exercises, the patients are actually changing their cup angles. A Schroth method is a very active method in Germany, fully funded by the public health, and teenagers come from all over the country, 200 of them at the time, into the Schroth Institute to do exercises all day long. This institute is bringing them the treatment what they need, whether it's mental health or bracing or exercises, until they're stable enough to go home into their community where they continue having Schroth physiotherapy. In this institute was the leader, Dr. Hans Rudolf Weiss, who is the son of Christa Leonard Schroth, and the grandson is for Katharina Schroth. So this family bringing the Schroth method to the world, let's say. I was fortunate enough to be mentored by 5 years by Christa Leonard Schroth, and she appointed me a Schroth instructor, a Schroth teacher in 2014. I have taught many other schools since then as well, BSPTS, and now I'm teaching SSOL School Schroth, which is a very up-to-date Schroth education. What does the Schroth exercises have in common? It's really to reduce the persistent asymmetric loading. It can increase the existing scoliosis if we maintain this asymmetric loading. According to Ian Stokes, this vicious cycle should be halted or, if possible, reversed. The vicious cycle is based on loading of the spine, as well as Lewis showed us in 1877 when axial loading happens on a straight spine, pushing it down. The little elastics were set up here, pushing it down, as scoliosis will also easily progress. These are just examples of asymmetric loading, asymmetric muscle imbalances during the scoliosis patient development. The Schroth method, being a physiotherapeutic method, includes all the elements of axial elongation, sagittal normalization, deflection, derotation, and the correctional breathing technique with stabilization exercises. So you can see a right curvature here with the pelvis imbalance, a very inverted back patient, a gymnast, and here we're doing the Schroth exercises with a very open concavity, very reversed, almost looking curvature. Definitely the pelvis is nicely overcorrected while the patient is kyphosating and managing her correction. These are postural, some of the postural deviations can be easily treated with the exercises, and the structural component of the curvature may remain. So the functional and postural component could change the cup angle, which means a total different treatment for this patient when they go for an x-ray and they show 50 degrees, or when they had some physiotherapy, scoliosis-specific exercises, and they have 35 degrees. If it is an immature patient at 50, they will be asked to have offered surgery, and if it's an immature patient, will be offered to have brace treatment. So it's a total different brace or surgical treatment depending on the patient's posture. This is the ideal situation. When the patients are diagnosed early with a 20-25 degree curvatures and enrolled in scoliosis-specific physiotherapy, in this case based on the Schroth method, when they go back to the hospital for the 6-month follow-up because they were given the observation treatment, but they actually did the exercises instead, they producing these perfectly almost straight spines. And if the Children's Hospital wouldn't order another x-ray of these children, we would have not known how effective the Schroth method exercise was. These children did not have any brace treatment. And this is what happens when we reduce the asymmetric loading, when we have a curvature, which is quite uh, needing a brace, but this happened during COVID, so the bracing was a little bit delayed and enrolled in scoliosis-specific physiotherapy. You can see the wedged disc at the beginning of the development of the progressive scoliosis. You can see here I highlighted the wedged discs, and during and after the checkup, the following x-ray showing no more wedge disc, much less rotated, much less curved spine, normalization of the disc, normalization of the decreased or reduction of asymmetric loading is resulted almost the reversal of the vicious cycle with the Schroth method. We see other evidence of changing of the rib hump. This was a patient from Montreal, was seen in a hospital and just told to be very active and come back in 6 months. By the time she came back 6 months later, had a huge progression. And with the double rib contour sign and the rib index measurement, I'm able to follow the size of the rib hump here. So when we are treating these patients, gradually the cup angle improving and the rib hump is reducing, mostly because the concave and the convex side is getting much more closer to normalization. So this patient also was a surgical candidate, but elected to work on the Schroth method without the brace. We also treat combined hyperkyphotic scoliotic patients, and this is a very nice improvement, not just posturally, but the scoliosis as well. And hyperkyphosis patients often have a mild scoliosis coming on with them. So these are next patients will be in the gray zone. Gray zone are curves of 40 to 50 degrees, and they are often not advised anymore bracing if they are reserved 3 or 4. And this is a young child, younger, who was diagnosed with 48 cup degrees, were not offered the bracing because the curvature was very progressive and they were suggesting surgery. The surgery was refused by the family, and this patient was wearing a Rigo Shano brace prepared by Dr. Rigo himself, as well as doing the scoliosis-specific physiotherapy. Is not just to reduce the cup angle, but normalize the muscle asymmetries and the posture with the treatment. Another patient being in the gray zone, diagnosed with 47 and 44 cup degrees, a double major curvature, and wearing the brace compliantly, doing the physiotherapy, not just normalize the posture, reduce the pelvis shift and a cup angle and a rotation, but avoided surgery. So these are patients in a gray zone. This is not even a gray zone, it's a much past the gray zone, 56 cup degree patient with a very severe scoliosis here, was braced and treated during the wait period of the surgery. The patient stayed on the surgical list for 1.5 years. By then, she reduced her cup angle for 45 degrees, and then she continued the bracing treatment and scoliosis-specific physiotherapy and was removed from the surgical list, making the list shorter. What happens if we leave these postural imbalances untreated? In this case, all these little so-sort emblemas on the bottom means these cases have been presented at the international conference in either a case series or case studies. And this patient was going to be left without any bracing treatment or any treatment because she was a little bit more mature by then when she went to see the spine surgeon. And this is a similar curvature, very similar curvature, was not treated, observed, both patients were observed. One ended up in surgery, the other one actually went and obtained a brace and did scoliosis-specific physiotherapy. So you can see the difference. This is straight without the hardware. and it could happen if the scoliosis is still flexible. This is the patient who came to us with this very 40 plus degree curvature, which was going to be not treated by bracing, but went to actually sick kids, obtained the brace there, and ended up having a nice straight spine. So she might be at the beginning of the progression, might be in the middle of the progression, but long story short, she was not very structural. She was able to control the curvature with bracing and exercises. What happens when patients refuse the surgery? We actually treat them. We treat them with scoliosis-specific exercises based on the Schroth, Leon, CIAS, other methods, and make sure that we normalize their posture to decrease pain or preventing progression or future disability. We also have to make sure if the curvatures are very severe. In this case, this is a 70-degree curvature. We improve the lung function and also aesthetics. This patient's case was published. You can look it up. It is a young adult coming with a 70-degree curvature and able to reduce her curvature to 58 degrees just by scoliosis-specific physiotherapy. She has fused ribs, so in preparation of the fused rib release, we put her in a testing her in a brace, but she didn't go through that surgery. So scoliosis-specific physiotherapy should be and must be added to the standard of care. These patients can reduce their curvature if their curvature is small degree, 25 degrees and under, without bracing. And if they are braced, scoliosis-specific physiotherapy should be combined with the bracing treatment. If the patients are a little bit younger, they are called early onset scoliosis. They are very progressive, very aggressive curvatures, and they could be also treated with bracing and scoliosis-specific physiotherapy. It takes much longer to treat these patients, 4 to 10 years. And this patient was braced and grew up to be a healthy adult, avoided many, many growing rod surgeries, and able to live a healthy life without any surgical intervention. And she was also braced for 10 years and progressed a little bit during growth, but at the end, the 56-degree curvature ended up being a 25-degree, living happily ever after. The other curvatures for younger children also be managed by bracing and scoliosis-specific physiotherapy. If the brace treatment is helpful, we will see it within a couple of months. This patient actually has some congenital changes as well, but the bracing treatment was ordered from the Children's Hospital, and during the fast growth, she was able to manage the reduction of her curvature. We also treat kids who are braced or casted for their curvature by the Schroth method, added to the standard of care, and managing these patients with exercises. We also treat some of the neurological scoliosis. So I'm just adding that out there. All these surgical cases will be able to avoid surgery and managing the scoliosis posturally. What happens if the patient has spinal fusion surgery and the lumbar curve is still progressing? The compensation happens down below. This patient was sent to us to reduce the compensatory curvature below the fusion, but in a nice way, she done the exercises, opened the concavity, just like any other patients with using the Schroth method, and the revision surgery was avoided. What happens with the failed VBT surgeries if they don't want to go through fusion? This is a VBT patient who's unfortunately the rope has broken many places and the curve has progressed. We are treating this patient until further decision making is done to improve the posture and decrease the asymmetric loading and halting the progression. I'm just going to demonstrate here an exercise for you. And this is called Schroth walk exercise. The patient is starting to walk with the pelvis in the middle, ideally, and growing tall, doing the axial elongation, doing the directional breathing, doing the work with the isometric contraction in the convexities, making sure that there full correction of the spine according to the Schroth method. This is the patient who also was not diagnosed on time and missed out on all the treatment options, bracing and PSSE, but was not large enough to have a surgical intervention at 48 degrees. This is another exercise. It's called the semi-hanging. Same patient demonstrate this exercise. We use the wall bars for this exercise, and the patient is going to demonstrate a nice axial elongation as the pelvis is going to come down and being in the middle. And maintaining that stable pelvis, the patient is nicely elongating and eventually even overcorrecting slightly bit, because this type of main thoracic curves could have a little bit of overcorrection, which you see now going a little bit off to the left side. It will help to open the concavity even further and maintaining a very good muscle control at the convexities. If the patient has any type of deviation, whether the pelvis or the rib cage is coming out of the correction, the therapist is helping her to maintain that. You can see a little bit the pelvis acting up here. I'm going to notice that sooner or later, and there will be some adjustment for the patient's posture to not to compensate with the pelvis asymmetry. Okay, you can see how the rib cage is opening, expanding on the concavity, and maintaining a more normalized symmetrical posture doing these exercises. This is another short exercise called 50 per, very old style exercise, and the patient will be demonstrating how to do axial elongation and muscle activation in full correction. And this is, as I mentioned, a mature patient, 19 years old, who was not treated earlier. Still able to do the axial elongation, normalization of the rib cage, breathing technique is beautifully controlled, and maintaining, opening the concavity to normalize her posture. These exercises are done in a group setting or individually, and the patients are taking off their braces while they are engaging in the different type of exercises based on their curves. Some of them may be doing them now online or in person, and the group exercise sessions are very beneficial, keeping the patients motivated as well as they don't feel alone. We are trying to teach them how to do the posturing during the everyday activities and explaining how to reduce the asymmetric loading, how to arrest or reverse the vicious cycle with either the sleeping position in a more harmonic way. In this case, it's a major lumbar curve. You can see if it is sleeping on a convexity all night long, it's increased curvature. But if we use the gravitational force and sleeping on a concavity, this patient is much better off. I also check all their other exercises. This is a goalie, a soccer goalie with a double major 45-degree curvature, who's doing training, side plank, very popular exercises for training. But with the t-shirt on, the trainers will not see that is not performed perfectly. So we are just making changes to make sure the curves are very well looked after, The sagittal normalization during the training, also very important. Some of these yoga and gym exercises are believed to be helpful, especially the side plank, which has been published for certain type of curves, but people don't always do them correctly. So this patient wanted to do the side plank as she was reading about it, being helpful exercise, but clearly not looking as good as we can make it with the Schroth method physiotherapy. And we also educate them how to manage their daily activities, whether they're playing the cello or the guitar, and any other activities if they wanted to do in the brace or without the brace. This is a camp with the plank exercises with the brace on. We actually motivate the patients to stay active, engage in sports and activities, and we also trying to raise awareness of the harmful effect of repeated x-rays. So our group at the Scoliosis Resource Center, many families along the many years are advocated and raised funds for the local hospital to obtain an EOS equipment. And if you don't have an EOS equipment in your region, you can download the white paper research, which can be submitted to your hospital to arrange the obtaining this equipment. And this is our resource center and our scoliosis awareness walk, which is in this year gonna be on the 7th. You can see the the mayor proclaiming Scoliosis Awareness Day. This is Maya, our long-time volunteer and organizer. We also include the Sherman awareness as well as raising public awareness as much as we can and provide support for the families. Altogether, you have to improve the support and have to improve the care for the patients. No matter how you approach it, these teenagers should not be left alone and deal with their scoliosis journeys alone. If you can include in your community a proclamation of June 1st being a Scoliosis Awareness Day, or perhaps later on a Scoliosis Awareness Month. You can see our volunteers here, Tanya and Maya and many other volunteers helping us every single year, 10 years now, proclaim Scoliosis Awareness Day. So it is also raising awareness for the public. And we teach physiotherapists also about bracing and the importance of scoliosis-specific physiotherapy. You can see Rajiv here, who generously came and explained and taught them about bracing. And it's one of our physiotherapy educational course, certification course in Ottawa. So everybody is invited to the next walk. Feel free to join at June 7th at the New Edinburgh Field House, and we're walking together with families. And we still continue trying to raise awareness to create a scoliosis awareness, not just day, but week or month, possibly, to use that month to educate families all across Canada. You can see us walking through and being in a House of Commons 2 times where MPs were able to speak up, but unfortunately we did not have any arrangement to do a little bit more than a Scoliosis Awareness Day. So every child, teen should have free access to the least invasive treatment in Canada, regardless of location and socioeconomic status. Surgery is the only treatment fully covered in Canada. So we have to be able to provide treatment covered for the 90% of the patients who do not need the surgery, as you heard the statistics from Dr. Buachi. Raising scoliosis awareness across the country, asking for proclamation, organizing walks, or any other events will bring awareness. We must be successful in screening and early diagnosis, and we must be successful in halting progression in small curves or moderate curves by timely non-surgical treatment. And we must refer all preteens and teens on time, and waiting is not an option anymore. Reduction of wait time for surgery, as I mentioned, it is costing us a lot of money. We must do better for the children in the next generation. So with that, I will say goodbye and thank you for your attention. I will be happy to answer any questions you might have. And you're welcome to visit the Scoliosis Resource Center website, where you have many videos, many write-ups, how to apply for application of a proclamation for Scoliosis Awareness Day, how to organize an event, and you can raise awareness and educate your community. And lots of references here. So thank you for taking the time to listen to me.
Thank you so much, Andrea. Really, really impressed. Really appreciate you. I'd like to move on and introduce Dr. Jean Houlet. He's the chair of our coalition, and he has a really impressive resume. He's the pediatric orthopedic spine surgeon and clinician scientist at McGill University. He's at Shriners Hospital and Montreal Hospital for Children, and he's the chair of McGill Scoliosis and Spinal Research and medical director of Shriners Pediatric Simulation Center. And he's also CMO of his own company now. It has this fantastic app that is revolutionary, that I'm sure he's going to talk about. So I'll let you begin, Dr. Houlet.
Thank you so much, Karen. And that was a fantastic talk, Andrea. So I really wanted to just join my voice to this Canadian Scoliosis Screening Coalition. And I would really want to acknowledge Karen, Andrea, and multiple other individuals that have been advocating and fighting for the rights of our patients to get appropriate care. And a bit alluded to earlier, I do have to disclose that I did create a screening scoliosis app. So obviously I have I have a direct conflict, but it is one of my passions that it is high time that we make scoliosis much more center in the care of our young girls across Canada. So the objective of my talk, which is really just to add my voice, is to sort of highlight the current challenges that exist in Canada for patients that have scoliosis. I'm really here to advocate for early detection and initiation of early bracing. Even though I'm a surgeon, I can tell you that I'd be much more happy if we could treat patients without having to do surgery. And it's really my role, and again, as the president of the Canadian Pediatric Spine Society, it's really to endorse movements like this grassroots movement that is crucial in being able to change the disease burden of our patients that have scoliosis. So here's the scope of our challenge, is that currently in Canada, at least as much as we know, the incidence of idiopathic scoliosis is between 0.5 and 4% of adolescents. And if you look at the number of children across Canada, there's almost 10,000 patients that need to be seen or screened to make sure that they don't have scoliosis. And unfortunately, the current healthcare system is doing a poor job of being able to identify these patients. And again, so if you look at a study that was published in 2021, the majority of patients that presented to specialists presented too late to be treated with a simple treatment of a brace. And that's really a dismal result. And that if you look at some of the challenges, is that if patients did not have a primary care physicians, they were 2 times higher of the chance of having to have surgery compared to if they had a pediatrician. So the mere fact that somebody is looking at their back decreases the risk of him having significant spinal deformity, and thus is able to decrease the disease burden for that child. Now, the other challenge that we have is that if you look at x-rays, there's a study that came out of Toronto Sick Kids that 1 out of 4 x-rays were misread, resulting in a discrepancy in treatment of the current screening patients that were being referred to the specialists. So currently, the way that we're assessing and evaluating patients, we're missing a large component of them, and that the way that we're measuring them or assessing them is inadequate. And what's even more discouraging is that the same studies were shown in 2007. So in 2007, out of Saint-Justine, one of the referring hospitals in Quebec, 42% of the patients that were referred inappropriately. Essentially, they did not have any spinal deformity. Yet at the same time, 32% of those patients presented with late referrals, meaning that they actually needed surgery, and they missed a whole treatment group. So there is an obvious inability to identify and refer appropriately and early the patients that have spinal deformity. And the best way to address that is really increasing awareness. And that, so how do we do that, especially in the current healthcare system where we keep being told you got to do more with less? And I think one of the best way of doing that is really what this whole advocacy group or coalition for screening for scoliosis is, that we need to improve awareness, we need to improve early detection, and we need to improve access to specialized care. And that what we need is really to reinstall obligatory school screening during the critical years when the kids are growing. And then we could do that also with the idea of using new technologies and changing our approach to emphasize prevention rather than active treatment. And this is where, physiotherapists and as well as orthotists really play a role. Scoliosis is a condition that a conservative treatment can prevent disease burden. So here's an example of a child that was identified at the age of 7, and that initiating a brace as well as physio, we were able to, over a period of 5 years, to be able to actually treat his scoliosis. And that's the X-ray at the top. And then we have another child that's sort of had a 70-degree curve, which is typically a surgical treatment, that we're also put in a brace and we're able to control that curve. So my message to the group really is early detection, increasing awareness allows us to change the way that we see and treat these patients, and that it's really through a grassroots approach, and all of us reaching out to our members of parliament to change the current laws and being able to help these children before they get into trouble. I wanted to thank Karen to allow me to just say a few words. And I think that Andrea said it extremely well, that, the ability to detect early, initiate physiotherapy, then we're really changing the way that our children are currently living with scoliosis. Thank you for your attention.
Thank you, Doctor. Thank you, Jean. So next I'm introducing Trevor and Maxine.
Okay, thank you. Thank you very much. Those were really good talks by both Dr. Ouellette and Andrea. I learned a lot, obviously, and it's great to see Rajiv and Petra here as a fellow orthotist as well. Early detection is definitely a key, and we found that when we do our bracing, that if it's caught early enough, that we'll actually see better results. And we're going to go over some of the results. A lot of the first few slides that we put on here were already covered. So we'll just go into the slides of some of the clients that we've seen. We wanted to talk a little bit about the riser sign. That's an indicator as far as how much growth is left for these children. We obviously are better prepared and happier if we see a client that has a riser sign of 0. They have a lot more growth left, and it gives us the opportunity to alter the progression of the curve. So many curve types, but the two types that we commonly see are the C-shaped and the S-shaped. The S-shaped, of course, being a bit more structural and a little bit more balanced. C curves with gravity, if they're not treated, could to lead to further issues as the child grows. We're going to probably at the next slide go into some of the different braces that are available. This is not inclusive to all braces. Obviously, we are just including some of the ones that we're aware of. So the Scoli brace is one of them that's asymmetric. It's used a lot by chiropractors, and I'm sure some physios and orthotists as well. It's 3D imaged and measured to create a brace that looks like the one on your left. The middle slide is of a Boston brace, more of a modular brace in the past. but they're using 3D principles as well, and Chanel principles now more than they did before. The third brace, the one on the right, is the spine core that I think was developed actually in Quebec, and it uses different straps and certain lengths to try to derotate the spine. I've used this brace in the past. It's an interesting brace. It's one of the few soft braces that are used. The tendency is to go with hard bracing as opposed to soft bracing, but I think with smaller curves, it has been shown to be successful as well. The brace on the left is an asymmetric brace called the Genzigen brace, and it's a high corrective brace, low profile as well. The one in the middle is a Rigo Chanel brace, which also is an asymmetrical brace. I've been, unfortunately, in the field long enough to have fit some of the Milwaukee braces, which is the brace to the right. It's hard to believe that some of these kids actually slept in these braces, but they're used for higher curves that are higher than T7, that can't be reached with a regular plastic brace. Nighttime bracing used to be popular, and it's gaining more popularity again. The one on the right is a Charleston bending brace. Works really well for single curves, especially if they're flexible. You can unbend the curve. But if you have a double curve, it'll actually decrease one, but possibly increase the other. The brace on the left, the red one, is the Providence brace. Works well for single curves and double curves, and is used at night. We're going to go over some treatment examples. I'm going to let Maxime take over here.
So we use in our practice Genzigen brace, and the developer of this brace is grandson of Katerina Schroth and son of Crystal and Schroth, Dr. Weiss. So here you can see single thoracic curve and very good in brace correction. This is how it looks. It's scan-based, and it's made in unique software developed especially for this issue. It's not mass market software. Here you can see double curve brace, how the patient looks with the X-ray. In the brace, you can see very nice correction, and this is how it looks the scan of the body, and this is how it looks the brace model. Here you can see single lumbar curve. This is a scan of the patient. This is the model of the brace, and you see very nice, let's say, overcorrection or overcorrection of the pelvis. So initially, patients in standing position, pelvis shifted to the left, and in brace in opposite, and we have very nice in brace correction. Another sample, you can see the patient with 60 degrees. We saw a single solid lumbar curve. This is a scan of the patient, and it's a brace model, and you see it's like deformities that looks like mirrored, and we have very good in-brace correction. In some single curves and flexible single curves, we can achieve X-ray overcorrection in the brace sometimes. And for bigger deformities, like more than 40-45 degrees, the main aim first step is to make the balance of the curves. So you can see in the brace, both curves are balanced. And for very big deformities, we have some special models. And again, we try to balance the curves to achieve better clinical outcomes. Like in this case, so you can see single thoracic curve more than 60 degrees. In the brace, we have like double major, and this is intermediate result, so you can see very nice and balanced body. And Trevor, your turn. This is
so these are
cases from Canadian patients.
These are clients actually from our clinic, and again, the whole focus that Andrea and Dr. Ouellette have spoken about is early detection. And that is the key to seeing the best results. These cases I think that you're going to be seeing going forward are all RISR 0, caught fairly early. Curves are small, pliable, and because of that, we can put them into a brace. All these x-rays out of brace have been at least 18 hours out of brace. And in this case, small curve, but very good results so far. Next, we have a bigger curve, again, RISR 0, but unfortunately, this client was caught a little bit late. She went on to, I believe, Montreal to look at surgical potential or possibilities. However, we were able to put her in a brace, and you can see from 2020 to 2025, she grew a lot. She wore her brace. She was very compliant, and I think that's one thing as brace people or orthotists, compliance is the key. We can make a very well-shaped brace, but if the patient doesn't wear it, it's not going to be effective. This is a case where the patient wore it 22 hours a day, and she went from being a surgical candidate to now having a very nice looking spine. And I believe she's about 17 years old now. So very good result. And that was taken at 24 hours after the brace was taken off. This was a boy that we saw. I believe he was 11 years old. Same thing, early detection. RISR 0, we put him in a brace. In brace, x-ray looked very good. When he came out of the brace in 2024, she's still wearing it and will wear it for a little bit longer, but you can see that he's improved just by wearing the brace. I got to say that the last two cases, they actually did Schroth therapy in conjunction with bracing. This gentleman didn't, and still so far has a very good result. This is an interesting case. So this client had been fit with a Providence brace. So if you look at the second x-ray, that's a Providence brace. That's a nighttime brace, looks really good. But they also went into a daytime brace. And as you can see with the daytime brace, the correction was not as good as the Providence. In fact, you could make an argument that it looks very similar to the unbraced first x-ray. They came to us, we put them in one of our braces. The Providence brace was in a lying down position. So the fourth image that you see, that was lying down as well. And you can see the results are very similar to the Providence brace. We then had the young lady with the same brace standing for a regular standing x-ray. And you can see that the correction in the brace, standing and lying down, the same brace had the same effect. So it can be achieved with one brace. This lady or young lady, again, caught early, early detection, still had a fairly big curve, had very nice correction in brace, and now, 2 years later, a nicer looking spine, more balance, good symmetry, and she also is a very high level ballet dancer. I have to also mention that a lot of the kids that these x-rays have been taken of have and are very active. And I think that's an important thing that actually Andrea also brought up. This, another case, early detection, caught when this child was about 10 years old. She wore her brace, then stopped wearing her brace. Her curve got a little bigger, scared her. She went back into her brace full time. And at the end, I saw her 2 days ago, and she has progressed to the point where progressed in the sense that she doesn't have to wear a brace anymore. So she was in tears. She was really happy. But she wore it 22 hours a day and was weaned off it the last 6 months. But you can see good correction all along. This one, a lumbar curve with a subtle thoracic curve. Again, we put this client early detection once again. in a brace. She grew quite a bit, and you can see the results after a couple of braces. She has a very nice spine. The lumbar curve has reduced significantly, and she looks more balanced. This is, I think, what also Maxime was talking about earlier. This is one of the clients we saw that was able to be overcorrected. When the overcorrection occurred, some of the doctors that were taking care and the nurse practitioners were a little concerned that it was going the opposite direction, that it might cause a reverse curve. It didn't. Luckily, it kind of balanced itself out, and it curve looks a lot better than when she first started. Last one again, early detection is the key. This is what all of us are here talking about. If we can catch these curves early, we can help straighten and most importantly, stop the curves from progressing, but we can actually alter the history of that curve going forward. And this is another case where clients had a curve caught early, flexible curve, diligent about wearing their brace, and the results 18 hours after are pretty well a straight spine. That's basically our talk. Again, to just reiterate what Dr. Ouellette and Andrea have said, early detection is the key. Some of the key things we look for that will help with success with bracing and changing the course of the curve is flexibility, age, and wear time, and the type of curve. I know when I was learning about scoliosis, I was always told that, the bracing is just going to stop the curve from getting bigger. But I think what we're finding with bracing and with Schroth, because again, a lot of these clients that we're talking about are also doing Schroth, we can alter the course of the scoliosis, and we have. So, and Andrea has as well. So it's exciting to know that bracing is not just to stop curves from getting bigger. It's exciting to know that we can actually make them straighter without going the surgical route. Thank you.
Thank you so much, Trevor and Maxime. And next we have Rajiv Kelsey from Ottawa.
Hello. Thanks for inviting me to this seminar. It's been very interesting. I don't have slides, but I'll just share a few of my experiences. I'm an orthotist in Ottawa, and probably more than 10 years ago, Andrea Lebel had reached out to our department, and I had been working with scoliosis kids, but she really got us involved in thinking a little bit differently about how we treat scoliosis, and learning there's a Rigaud-Chenot concept of bracing. And that's what me and my colleague, Ted Radstick, also took the course from Dr. Rigaud. We were fortunate to be able to do that. And I think we have a pretty good working relationship with Andrea, because many of our kids that come to us from the Children's Hospital are also, and sometimes even see Andrea before we see them for bracing. So that's kind of a nice, and I really like the collaboration of being able to speak to Andrea about a patient that I might be having some trouble with bracing, or if I think, they could be referred to her as well. So it's an important relationship to have a physiotherapist available like Andrea that we can work with. And also I want to mention with, as orthotists, we tend to work in our own little bubbles almost. And I really value when I can talk to orthotists like Trevor and Maxim and other orthotists in terms of what they're doing around scoliosis, because I think the collaboration is so important. And I'll probably be reaching out to you, Trevor, at some point to talk, and I hope we can collaborate a little bit or learn from each other. That's important. Something that Trevor mentioned about the early and around early detection is, I find when I see a child that's maybe 10 or 11, they're much more open to, in most cases, wearing a brace and being compliant with how many hours we expect them to wear it, whether it's 18 or 20 hours, versus when I see somebody that comes in for the first time, say a 13-year-old girl, and then there's all the issues of what am I going to do if I have to wear this at school, or even just the idea of having to wear a brace for an extended period of time is much more. And that's something I have to have a conversation with the family and the patient as well for quite a while before I start any measurements or anything. And that's so I find younger kids, they're just easier to get into the idea of bracing. They don't have the same, I guess, social issues as an older teen would. And I guess in terms of our practice, since about 2020, I used to do all the casting by hand, and it's quite involved, doing a plaster cast on a kid and having them to make the mold and then making the brace. So since 2020, we've been using digital technology. We've been scanning digitally and using software to do our modifications on a computer. And it's taken a while to learn. I'm still learning, 5 years into this, and still trying to perfect our techniques or improve on our techniques. But it's a much better, I think, experience for the patient. They don't have to be cast with plaster. It's quicker, and so in that respect, it's not as maybe traumatic for them. So yeah, I think that's mostly what I wanted to add.
Thank you, Rajiv. And next we have from Montreal.
So my name is Piotr, but Peter is the user-friendly way to say my name. So essentially, I'm just going to give you guys a little bit of our Quebec, Montreal reality. So I work out of the Shriners Hospital with Dr. Willette. So I'm his brace maker, and Dr. Saran's and the nurse practitioners as well. So I pretty much do all of the braces coming out of the Montreal Children's and the Shriners. Our reality is a little bit different across Canada because I think of billing codes, and I think that's kind of how we all end up doing what we do, but with a slight tweak or modification. So we do have the benefit in the province here to have a daytime brace code and a nighttime brace code, which allows us to essentially double brace our patients. And with the benefit of getting a night brace and a day brace when it's necessary. So that's a little bit what I wanted to kind of introduce for those that are maybe not too used to that system, where with the team that we work with, we often introduce the night brace first as a brace initiation treatment. And later on during the treatment, there's a potential to add a day brace. If the curve is under control with the night brace, then we simply essentially forget altogether about the day brace and allow the treatment and the follow-ups to continue without ever even discussing a day brace. But if there is either curve progression or things aren't responding ideally with only a night brace, then often a Cheneau type brace will be added to the mix. And over the years, we've kind of what was mentioned earlier with Andrea's presentation, Dr. Willette's presentation, Trevor and Rajiv. I think all of us, we're all seeing improvements and correction, things that in literature kind of weren't there years ago. And so I think it's something that we've been seeing a lot. And I think that, the whole 3D approach to scoliosis and building your brace in a derotational manner has really had an impact in terms of seeing not only curve prevention and prevention of progression, but even correction that actually stays and that's long lasting. So that's something that we've been noticing more and more. In terms of how we make our braces and all that, I think Trevor, Rajiv, we're all doing similar things, and we're just doing it our own way. We use 3D imaging as well, and we use actually casting because I have a huge neuromuscular patient base where I still to this day have a little bit of an issue with 3D imaging because when you can manipulate your patient, when you can control the cast before it hardens, especially with the neuromuscular patients, in a wheelchair and whatnot, you get to lay them down, you get to control the cast. There is something to that, whereas you don't always have that control with 3D imaging. But for all of our AIS patients, I think we all use a very, very similar process. So that's a little bit kind of what we do out of Montreal. And that's a little bit kind of want to let you guys know a little bit of our kit here in Montreal.
Thank you so much, Piotr.
Not a problem.
And thank you all for coming tonight. I see we have Dr. Kirby Upshaw is here. I don't know if he wants to say a few words.
Well, that was very nice to hear everyone present. I know it's kind of the long end part of the day, so having everyone put in the extra effort to explain everyone's reality. I think it's important whenever any of these things are being raised that we get everyone's reality. Obviously, for Dr. Ouellette, myself, Piotr, obviously we work together, and Andrea, we've worked together as well. But to get collaboration across Canada and get everyone's reality, I think it actually lends to what Canada faces specifically, because even though Montreal might do something and Ottawa might do something, it might be completely different somewhere else. So the more that we sort of talk and discuss the difficulties across Canada, I think it's better suited to finding a solution. So thanks to everyone for taking the time and effort to present and to help push this forward.
Oh, Pietro, I see that there's a question here from a parent.
Yes, I got that. When we do presentations like this, there are we speak in general terms, and sometimes we have to just not forget that there are case-by-case situations that, in general, we will use a certain approach. But in terms of really, looking at all the details of a patient, there are occasions where the general procedure is going to be a little bit different and more fine-tuned to the realities of the patient in question, whether it's age, whether it's risk or sign, whether it's sometimes mental health issues and all that. So yes, there's a generic, not a generic, but a more kind of standardized process by introducing the night brace first, and if necessary, we add the day brace. But there are occasions where we start off immediately 23-hour bracing with a combined day and night brace. But again, it's really hard to kind of, overly, diagnose a situation right now and why a message would be a little bit different from here in a presentation versus in real life, simply because I think that there's a lot of factors to consider in clinic before the team will choose a more specific response to the specific patient.
Thank you. I just want to say thank you to everybody. I really appreciate this. I think this was a great first webinar for our coalition, and I hope I can see you again. And I think we're going to get this done. I really believe in our cause. And again, thank you so much, and thank you everybody for attending.